Hello, good morning, or good afternoon. Welcome to our webinar on global strategies to reverse the rise of liver cancer. It's a pleasure to be hosting this webinar today. We have a very packed agenda. My name is Vanya Wisdom, and I'm a Senior Executive Editor and Oncology Ambassador at the Lancet, and I will be co-hosting this webinar with my colleague Helena Wang, which I will introduce shortly. So today you will hear about the Lancet Commission on liver cancer, and we'll have 4 speakers. All our speakers have been commissioners at the Lancet Liver Cancer Commission, and they will cover the key findings and recommendations of the Commission. We will then hear a more focused presentation on the global burden and prevention, followed on by the presentation on early diagnosis and treatment. And finally, we will hear about the differences between the East and the West. At the end of all presentations, we'll have a panel discussion, and there will be opportunity for you all to send us some questions. My colleague, Helena Wang, she will introduce each of the speakers individually very shortly. Just some housekeeping points before we start this presentation. If you'd like to submit a question, please use the Q&A box on the dashboard. And you will hear a lot about the Liver Cancer Commission today, and the report of that commission will be available on the dashboard, where we'll have a few resources related to the content that's going to be presented. At the end of the webinar, we would really be, I would like to encourage you to complete the 30-second feedback survey. That would be very helpful for us to learn for future webinars. So without further ado, I would like to introduce my colleague, Helena Wang. She's our Senior Executive Editor based in Asia. Helena, over to you.
Thank you very much, Vanya. Hello, everyone. I'm so thrilled to co-host this webinar with my colleague, Vanya. As Vanya introduced, I'm the Asia Senior Executive Editor of the Lancet, and I'm based in Beijing, China. So join me today are 4 distinguished guests who are also the commissioners of a Liver Cancer Commission. Let me just give you a very brief introduction. They are Professor Jian Zhou from Department of Hepatobiliary Surgery and Liver Transplantation of Zhongshan Hospital, Fudan University from China. Professor Stephen Chen from Department of Clinical Oncology of Chinese University of Hong Kong, China. Professor Jordi Brooks from Barcelona Clinic Liver Cancer Hospital from Spain. And Professor Hongmei Zeng from National Central Cancer Registry, National Cancer Center Cancer Hospital of Chinese Academy of Medical Sciences and Peking Union Medical College of China. I know we have a very packed agenda. So without further ado, I'd like to introduce our first speaker, Professor Jian Zhou, to start the presentation to introduce the Liver Cancer Commission, which was published in the Lancet just a couple of months ago. Over to you, Professor Zhou.
Okay. Thank you, Helena, for your kind introduction. First of all, I would like to thank you and thank you, Lancet, to the journal of the Lancet to give me the opportunity to work with my teacher, Professor Brochure, and Hongmei and Stephen, and all the other colleagues to publish this Lancet Commission on liver cancer from prevention to treatment. So let me introduce you briefly to introduce the Lancet Commission on liver cancer. From report to practice, implementation strategy for the Lancet Commission on hepatocellular carcinoma. The Lancet Commission on addressing the global hepatocellular carcinoma burden we focused on the prevention to treatment. Our target is to decrease the incidence and mortality of liver cancer globally. Let me introduce from 6 areas. We have 3 new findings in our Lancet Commission report. By 2050 means 25 years later, liver cancer cases and deaths are projected to double, respectively, requiring at least 2% of annual reduction in to reduce this trend. HBV and HCV-related liver cancer will drop down. However, alcohol and MASH-related liver cancer will increase from globally. At least, and also another new finding is at least 60% of liver cancers. That means 3 out of 5 cases are preventable. If annual reduction of 2 to 5% can be achieved up to 2050, at least 8 million new cases of liver cancer can be prevented, and at least 7 million lives can be saved. So we issued or launched 10 actions to reduce this burden. So first is strengthening viral hepatitis prevention, screening, and treatment. And we make a very good case study from Western country such as Italy. So they have a very good strategy from government-led national screening program, integration of screening with routine healthcare services, and the universal access to care with the full coverage, and the collectively multi-stakeholder approach. The second is reduce the alcohol consumption. The third is control the environment and other risk factors, especially in Africa. The food should be free from aflatoxin. And we also make a case study from Qidong, the small city nearby China. They have the liver cancer mortality of 5-year survival, from 2.5% to 30% recently. And the fourth action is to prepare the increase in method and MASH. The case study, very good study, a case study from the USA. They have good strategy to need for scalable intervention, primary care, and public awareness. The fifth action is raising awareness of liver health. We can through the liver association or World Liver Day, or liver cancer day, or liver cancer month, and through way to enhance the awareness, public awareness. And the sixth is to improve the early HCC detection through the screening and surveillance, especially for those high-risk population. And there is a case study, very good case study in our Lancet Commission from Japan. They have a good strategy to such as a nationwide surveillance program, free and routine hepatitis screening, full insurance coverage, strong public and physician education, and also the government-supported hepatitis treatment. We also have a good case study from our Liver Cancer Institute, Shanghai, our hospital, from 62-year analysis of more than 20,000 HCC patients who underwent hepatectomy. You can see this picture recently in the recent study, recent decade. The 5-year survival is as high as more than 70%. Even the 10-year survival is as high as more than 50%. This is greatly because of the median tumor diameter is from the 10 centimeter in diameter to recent to 4 centimeter in diameter recently. And the seventh is a standardization of non-invasive diagnosis of HCC using imaging bicycle and the Lee rates. And S is addressing the east-west difference in clinical management. We should shortening the divergence, narrow the gap between the east and west. We should learn from each other, from the experience from both east and west. And the ninth improves HCC survivorship. Not only we emphasizes on survival, but also the survivorship. So we should early integrate palliative care in HCC management. The 10th action is to facilitate access to treatment, especially in the low-income countries. And we also make a case study from Egypt. We should need the government should lead to make access to treatment more closely. The ultimate objective is to ensure our annual at least 2% of reduction in the residence. So, as the editor-in-chief of Richard Houghton said, the work of this commission has been completed through the most remarkable collaboration and the international collaboration of experts. That's what it will take if we're going to turn around the present trajectory of liver cancer. A remarkable international collaboration. Let's back work and begin today. Thank you.
Thanks for Professor Zhou's presentation. So let's invite Professor Zheng Hongmei to give us a talk on global burden and prevention of liver cancer.
Hello, everyone. I'm Hongmei Zheng as an epidemiologist, and I want to share the rationale. That's why we focus on global liver cancer prevention and share global liver cancer statistic to you. Liver cancer is a global disease. It's the 6th most common cancer and the 3rd leading cause of cancer-related mortality. Right now, we have 866,000 new cases every year, and HCC is almost contribute the major subtype, about 80%. And when we see the progress of global liver cancer control, we can see from the map that there is uneven progress in global liver cancer control. We can see as the bright orange color showing there are countries with increasing trend, and historic high incidence countries such as China, Korea is facing decreasing trend. And European is showing an annual increasing trend. And given that liver cancer is highly heterogeneous, we can see that by etiology, there are uneven progress for the liver cancer epidemiology as well. We can see almost most of the countries are facing with increasing trend for liver cancer due to MASH, and especially in European countries, there are increasing trend of liver cancer due to alcohol use. Even though HBV and HCV are preventable, and we can observe such developed countries such as the USA are still facing increasing trend of liver cancer due to hepatitis B and hepatitis C. So that's why we raise the global goal to our annual reduction of at least 2% in the age standardized incidence rate. Given that many countries are still facing increasing trend and the population age, at least 2% of the age standardized incidence rate is necessary to reverse the trend of rising burden. And we further calculated the PAF for liver cancer. At least 60% of liver cancer are preventable, which offer us a precious opportunity to stop the disease. But when we look at the global HPV vaccination status, we can observe that there are inequalities among countries. In China, in developed countries, we can see the HPV neonatal vaccination is almost 100%, but there are some countries still facing low HPV vaccination rate, especially in Africa. There are only less than 30%. There are a lot of barriers that stop the global HPV vaccination status, such as vaccination hesitancy, poor awareness, limited vaccination access, lack of legislation. And we're still facing with a lot of population having HPV antigen cell prevalence. In China and in Asia, Vietnam, there are higher prevalence of HPV SAG, and surveillance is crucial for the early detection of this high-risk population. We still face challenges in antiviral therapy in HPV and HCV treatment. Globally, only less than 20% of HPV-infected individuals receive the treatment. And in Southeast Asia and Africa, the numbers are still lower, and which is far below the WHO target to receive 80% of antiviral treatment coverage. There are a lot of irregular medication, poor adherence due to lack of knowledge, and long treatment cycles. Well, this map shows the global alcohol consumption. We can see that in European countries, the alcohol consumption rate is especially high, and there is no decreasing trend. WHO has initiated the interventions to prevent and reduce alcohol-related harm, but the actions are still slow. And when we see the global prevalence of BMI, and we can see in historically developed countries, the prevalence of BMI is increasing, and with high prevalence, which are the risk factors for liver cancer. So that's why in the 10 recommendations for our Lancet Commission, 6 are about comprehensive prevention. To stop the increase of liver cancer, we call for comprehensive prevention, not only in vaccination, but also in alcohol consumption reduction, control of environment risk factors due to climate change, and preparing for the increase in muscle. Raising awareness of liver health is very important to everyone, especially for the high-risk population. That's all. Thank you.
Thanks so much, Hongmei, for your introduction about the liver cancer burden globally, and have many insights and reflections on the Commission. So next, I'm very happy to introduce our first author of the Liver Cancer Commission, Stephen Chen from CUHK, to talk about early diagnosis and treatment of liver cancer. Over to you, Stephen.
Hello, Halina. Hello, everyone. It's really my pleasure to be here today in this Lancet webinar. I need to apologize for some unknown technical reason. My webcam is not working, but I believe this will not affect the quality of my presentations. So I will briefly cover the early diagnosis and also very briefly talk about the treatment for the liver cancers. Let me move my slide. So about the early diagnosis, the first slide I would like to show you is the distribution of the different stages of the liver cancer in different regions. On your left-hand side, you can see in some areas where there's a surveillance program like Japan, the diagnosis of the earlier stage is accounting for high percentage, like 62%. But in areas where there's no governmental or regulatory implemented surveillance program like Taiwan or Hong Kong, you can see the proportion of the early stage like BCLC 0 or 8 is much lower than Japan. And for your information, if we can treat the patient at the BCLC 8 or 0, we do see quite a high proportion of patients being cured or disease-free from the cancer. But if the patient have more advanced stage like B or even C or D, basically the long-term survival rate is impossible. And therefore, this highlights the importance of some surveillance program or screening tests to detect early stage HCC before the patient becomes symptomatic. And typically, most of the guidelines will recommend the ultrasound of the liver plus or minus the blood test for the alpha-fetoprotein every 6 months. And generally, based on some clinical trial, some randomized study, or some real-world data, we know that the patient who have a diagnosis of HCC in the surveillance group tend to have a smaller HCC, fewer number of the liver tumor, and also the longer survival rate. But the problem is, even so, you can see still a lot of patients, they die within the 5 years' time. And definitely, we need to do better. So in this Lancet Commission paper, we have discussed a number of the solutions or suggestions. The first is we know that sometimes imaging may not be acceptable to regular imaging may be quite burdensome to a lot of citizens or the patients with cirrhosis or chronic hepatitis. And therefore, one of the options to develop more blood-based marker, which is could be more specific or more acceptable to the general public. Another possibility is we may develop some more specific and yet hopefully cost-effective imaging methodology like the abbreviated MRI. There's some ongoing study addressing the performance and also the generalizability of the abbreviated MRI. And also, we would like also have suggested some method to improve the compliance. For example, nowadays, a lot of us have the smartphone. Could we make use of a smartphone to remind the high-risk population for the surveillance program? Or we could bundle the liver screening test with some routine body check like the checking of the cholesterol or glucose for those high-risk populations. Last but not least, we may develop some point-of-care testing that the result of the test become readily available once taken, like we are checking the COVID or the influenza with some rapid tests nowadays. We hope and believe this will improve the performance or the compliance of the surveillance. Then we move to the next part. Perhaps I will not go into the details of different treatment. Professor Zhao already shown us that with the surgery or with some novel therapy, we could improve the outcome of those patients with either early stage or inoperable, more advanced stage of the liver cancer. But I would like to highlight one area, which has also been a key area to discuss in the Lancet Commission paper, is that drug access is an issue. We may have a lot of effective treatment, but many patients could not have access to those therapy. So we have discussed some possible solutions like increasing use or development of generic drug, or there may be some innovative purchase program like the bulk purchase agreement, which may push down the price of those therapy. And of course, with the improvement negotiation between government and the industry may also help. And from other cancer type, we know that sometimes we may rely on some more lower dose of the treatment, which also can improve the cost effectiveness of the therapy. And this is my last slide. I think our previous speaker has already shown us that we need to take action now because the problem is more serious than we expect. If without any action, the liver cancer in terms of the number and also the death actually will be doubling in the next 20 plus years of time. So we need to take action now, not only from the clinicians, from the public, but also from multiple levels like the policymaker or the industry to work together to improve the prevention and the screening and the treatment of liver cancer. So that's the end of my presentation. Thank you.
Thank you so much for your presentation, Stefan. And we hear your call to have action right now. So last but not least, let me invite Professor Jody Brunix to give us some insights about regional differences, especially differences between East and West with regard to liver cancer risk factors, modification and treatment, and also the future of liver cancer. Over to you, Professor Jody Brunix.
Thanks for the introduction. Good day to everybody. It was a pleasure for me to be involved in the Lancet Commission paper and also to be here in this presentation. I have no slides to avoid issues with the talk. The epidemiology has already been presented, and the point is that vaccination for HBV and treatment for C virus will decrease the role of these viruses in the risk profile of the patients. What is going to remain, and this is the big problem, is alcohol consumption. And this overlaps with the fatty liver disease that is related to the obesity epidemics. And I think that the main challenge in the next years will be to make sure that governments and health agencies introduce population plans to reduce the risky consumption of alcohol. And I have to say that this is frequently neglected because there is a stigma. But it's clear that alcohol is a cofactor for all the etiologies, both viral disease or fatty liver disease. If alcohol is there, the progression of the disease is obvious and the risk of earlier death is in place. And this is one of the first things that governments should take action. What is the difference between the East and the West? It is affected not only to risk factors, because B virus is more prevalent in, for example, sub-Saharan Africa, that is in need of major health intervention to prevent the dissemination of the virus, but also in Asia. In the West is more C virus that has decreased a lot, and still, as I said, the alcohol is in place. The main difference is to what extent the different health systems are homogeneous, and it's obvious that this is not the case. It's not the same healthcare setting in Asia or in Africa or in Europe or United States or Canada. And this is what limits the application of early detection of liver disease that puts the patients or the population at risk of liver cancer and the point of entry into an early detection plan, as recently shown by Stephen Chan. So we need to make sure that there is a liver health plan in the community so that patients at risk of liver cancer are detected, if needed, introduced in early detection plans based on imaging. And this will prime not only the early detection, but also the treatment and the expansion of survival. And one of the points of difference is not only the access to systemic therapy that we presented in a recent paper in Lancet Regional Health by the International Liver Cancer Association, showing that there is a major disparity in access. But we have to secure in the future that people have access not only to systemic therapy, but also to surgery, transplant, ablation, locoregional therapies. And this is something that needs to be faced by the different governments in the different settings. What is the future? In the future, we need biomarkers to detect the disease early and not need to rely on imaging that demands time to be explored and going to the place to receive optimal imaging techniques. So these biomarkers should be developed, not in place now. And we also should have molecular profiling that is able to stratify patients according to what is the best treatment for them or the optimal one. And this is something that has not been achieved yet. It is present in other cancers, but in liver cancer, this is not really effective today. And it's something that needs to be developed together with the development of liquid biopsy that will avoid the need to take biopsies of the patients. And this is how we, at the very end, we will be able to manage this complex disease that is liver cancer, that requires multidisciplinary tumor boards involving hepatology, oncology, radiology, surgery, and all the needed specialties such as pathology and end-of-life specialists. And I think that this is what needs to be in place in the future, and thank you for your attention.
So Vanya, I think we can start the panel discussion, and I will let you ask the questions to start the panel discussion.
Speakers for this great presentation. Clearly, liver cancer is a very complex issue and global issue that the cancer community needs to address. Not just within the liver cancer community. I think it's important also the discussion on the wider context of non-communicable diseases. But from what I heard in the session so far, makes me feel optimistic. Actually, you offered a very hopeful outlook with the opportunity to prevent at least 60% of liver cancers. Does this mean we can be optimistic? If you were a policymaker, how would you use this opportunity to prioritize public health? I don't know who would like to take this question.
I can take it because I think that in all the countries, it has been obvious that treatment of viral hepatitis for C virus is effective and is in place in most of the countries. There is need to secure in some countries that are underserved. B virus vaccination is well known, and most health agencies in all countries have implemented vaccination, and this reduces liver cancer. What I am more concerned is with alcohol consumption, and this is something that is really neglected. And what needs to be done is for the governments to implement public campaigns to make sure that people understand the risk of alcohol consumption, not only drugs, cocaine, heroin, and so on, but alcohol is an increasing risk in young people, old people, medium-aged people. We are drinking too much. And probably one of the strategies would be to increase taxes, but mostly what you need to do is inform the population and make sure that in primary care, alcohol is inspected and probably corrected from the beginning, not waiting for the persons to be already in an alcoholic disorder.
And that's I think that makes sense. I totally agree with that view. And interestingly, of course, alcohol, as you said, is not only the cause for liver cancer, but also other liver-associated diseases. But more broadly, alcohol is a major risk factor for a lot of different cancers and for many non-communicable diseases. So perhaps there's also an opportunity to look at strategies that are not just vertical, but horizontal strategies that can make the population aware of the risks beyond just the liver cancer. Well, when we go by risk factor, if we focus on alcohol, perhaps there's also an opportunity to make the public health strategy more broad and to include other types of cancers and strengthen the interventions. I don't know if other colleagues would like to comment from the perspective on the region, other regions in the world, if there are different approaches.
This is Stephen. Can I just say a few words after Dr. Bruce's comments? I think I fully agree with Dr. Bruce. Apart from alcohol, and other risk factor that's come frequently overlooked is the fatty liver, or nowadays we call it mast cell disease. In our Lancet Commission paper, we did suggest that there's a very low awareness of the mast cell, not only among the public, but also sometimes among the doctors. Some doctors, they may not be aware of the severity or the impact of the mast cell, and also the policymaker. So we have suggested a more general idea of like promoting liver health. In the old days, we suggest more exercise. We monitor life called cardiovascular disease. I think maybe in a more country or the society level, we should also promote liver health. Apart from cardiovascular, you should do something to protect your liver, to maintain the health of liver. I think this something can also impact more populations.
I fully agree, but let me stress that when people with fatty liver disease is tested by sensitive tests for alcohol intake, between 1/3 and almost half of the patients have had excessive alcohol intake in the last 3 months. So and there are studies now showing that the main issue in the progression from fatty liver disease to real chronic liver disease with consequences is associated to the maintenance of alcohol intake in place. So this is something that is frequently neglected because it's a stigma. But what we need to make sure is that people with fatty liver disease are intentionally asked about alcohol and risk factors, because both are important.
Thank you.
As Valina said, we should be optimistic if our 10 plans of our Lancet Commission can be into action. We should at least 60% of liver cancer can be preventable. Regarding the alcohol, because alcohol is a problem, is one of the main etiology of liver cancer in the Western countries. But in China, in Asia country, like in China, also is a rising trend for alcoholic because the economy increased more, especially young people, to use alcohol. This is a lifestyle. So we should control alcohol consumption as to prevent the liver disease or liver alcohol-related liver cancer, as tobacco control to prevent the lung cancer, such as so. I think, but it's difficult to do that. A lot of life change, so we need stakeholders, all the stakeholders, including policymakers, public, even parents teach your kids from the young age, and the health association and the researchers to do together to control the alcohol-related liver cancer. Thank you.
Absolutely, we can't do this alone, right? I think partnership is an important word here. We all need to do our own part, and I think we really should highlight, like, it's not every one of the last big cancer commissions we published was on prostate cancer. Prostate cancer you can't prevent. There is mostly unamenable to prevention because it's genetics and it comes with old age. There's a massive opportunity here. 60% seems like really should bring hope to the population, because that will save us all the problems further down the line with treatment, with access, with much more complex issues.
There is another risk factor that I forgot to mention, is the risk associated to environment. So food or contaminated water. Even in London, I think in one of the parks, there is a pond that is contaminated with algae, and these algae have been linked to liver cancer. And then there are lots of things that are emerging as a potential confounder for the risk of liver cancer. So environment is going to be an important issue in the years to come. And I am optimistic that things can be controlled, but have to be made public so that action is taken.
Thank you. Maybe we move on to the next question. Helena.
Yes, I will change the question a little bit to AI. Actually, this is a question from the audience. As you can see, there are lots of discussion on AI recently. So the audience asks, can AI improve early detection and the diagnosis of HCC? How much should the field invest? So we're keen to listen to your ideas.
I am proactive as usual, but I think AI is going to influence lots of things, and probably one of the first impact will be to have these AI systems in place in primary care, when they would put together all the data that are collected in medical records and say, this person has this kind of biochemistry profile together with this record of events in his lifestyle, and he should be inspected, or he or she should be inspected for liver disease, and this will prime action to make an evaluation. In the evaluation also, AI will have a role, because lots of things in imaging or biochemistries or whatever are going to be put together by AI and raise a suspicion, and again trigger the action by physicians, and then also in diagnosis and so on. But the system still has to be developed. And now everybody talks about things are very easy and more effective than physicians, but we need to have trained physicians that are updated not only with the current knowledge, but also with developments. And AI is going to be one of the developments that's happened with CTs or MRI. When I started, CT and MRI was not in place, and we incorporated it. So you need to have physicians or healthcare systems that are continuously educated to incorporate the developments that are positive for the system.
Yeah, I agree with you that the physicians need to, we shouldn't be completely rely on AI. AI is still relatively preliminary in early diagnosis of HCC. So do any other speakers have any comments to add or share?
Just a quick note from Stephen. I agree. On one hand, there's a two-way we can develop AI for early diagnosis. One hand, we can improve the performance or precision, which I think already highlighted by Dr. Bruce. Another point we also discussed in the Lancet Commission paper is more like reminders or more from ensuring the compliance of the public about with the screening. For example, I think one day we may, based on the alcohol they bought from the internet, or their exercise level, or their background history, the BMI, we already can send a reminder to them that, oh, you have a high risk of liver cancer. And so that you need to go to some screening or see the doctor. This is another level we can more influence the public, not only for reminding them, but also for education. I know there's some platform like Tencent already developing this type of a strategy, probably not only for liver cancer, but this is one way we can also consider.
Yeah, good comments. Any other suggestions or comments? I don't think we have strong evidence on AI in HCC detection yet.
No, there are lots of suggestions of things that can be used, but the model has to be validated. So it needs lots of training. Yeah. Lots of experiments or studies are done in imaging, trying to see if by AI you can confirm that something is an HCC or a liver cancer. I have to say that we have hepatocellular carcinoma and cholangiocarcinoma that is also growing. So these are the two main tumors in the liver. And studies are there showing that you can detect and potentially characterize these tumors, but still you need to have the studies in tumors that have not been diagnosed and that are at a very early stage, that are the key target of early detection plans and life improvement.
I totally agree with you. AI is a good topic regarding the AI, because we are now in the AI era. So because I'm now the director of our hospital, I say to my colleagues, who neglect AI, who will be discarded by the new era. So AI actually involved everything, not only in our lifestyle, but also definitely involves our liver cancer prevention, from prevention to treatment. So the high risk population, or from screening, surveillance, diagnosis. Even in our hospital, we have study showed that even the MR, the result of MR imaging can predict the tumor microscopic invasion, or can predict the result treatment, immunotherapy treatment, can predict the result of the treatment. So in AI, in everything, you can imagine, just use AI. We now try to, now in our hospital, we try to build a multimodal to assist our doctors, or assist our doctors to write the medical history, to assist when you see the patient at the OPD, to help you everything. So AI involve everything. You can use AI to do everything for you. Okay, that's my opinion.
Yeah. The developments are fast, and those that are not able to take the good things or the positive things of AI will be left aside.
Yeah,
when you see... Sorry, continue.
I want to add one sentence: always human in the loop when using AI. Thank you.
Sure. Without brain, there is no artificial intelligence.
And we need to be also be cautious about AI because there are malicious AI as well. So over to you, Vanya. I think you have another good question to ask.
I think this is a good segue for this next question on what I think, after hearing your presentations, it seems there is a disconnect between all this recent technological and scientific advances on not just, the tools we now have for imaging, the new biomarkers, new surgical approaches. It seems like we've never been as well prepared with so many tools to treat patients as we are today. And yet the burden of liver cancer continues to increase. Do you think, do we have to rethink how we are investing, like globally, how we're investing in liver cancer, and how can we fix this disconnect between the different treatment modalities, and not just treatment, from diagnostics to treatment to all the cancer continuum? How can we recalibrate this balance between the burden and the needs of the population? I don't know who would like to go first.
I think that it will be easy, let's say, or simple to establish a frame for prevention, early diagnosis, screening, and staging. This is quite well established in terms of data and what needs to be done. Perfect. And then then what we have is the problem of how to decide the optimal treatment, not the best, the optimal treatment for a given patient. And liver cancer is a complex disease, and we recently proposed a model based on, let's say, facing the complexity, the lack of certainty, the subjective feeling that physicians have, and the emotions that play a role in deciding or recommending a treatment. And this needs to make sure that all over the world, or the different groups, agree on how to evaluate the evidence that is there to support a given intervention or another. And this is cultural. So in some settings, for example, surgery is the a priori best thing you can have, or transplant is the best thing you can offer a patient, even if the survival is dismal and you will not really benefit the society. And what we need to make sure is that everybody has the same understanding of the information that is available, of the strength of the information, and then try to homogenize the decision process, or at least make the decision process transparent and public. Why we recommend something in a given patient and why we recommend something different in a patient that looks very similar. The other thing is to engage in research in all the strata of the disease, including different populations from different settings. So normally, frequently, we have trials from the East, trials from the West, and what we need to define is trials that inspect all the population from different profiles, and this is what will give the basis for a worldwide homogeneous decision making. And I think it will take years, but the efforts are there. Years ago, there was no common definition for staging. Now we have the BCLC, maybe used in some places and in others not. But at least we have more and more an homogeneous language. And this is the first step for the worldwide developments.
Just one more quick note is usually I think the problem what we're facing in terms of research or developing some CC screening treatment is too fragmented. Each country or each region, we have our own guidelines, own thought, own bias, or whatever, prejudice. I think we probably need to really sit down together, form some working group to narrow down the differences, maybe through some organizations. And another possibility is we know that a lot of things are driven by industry. Of course, industry usually their priority is more developing their own product. But I think as a researchers, or as a clinicians, or as a policymaker, we may work together or push the industry to work on some more global topic rather than only just on the industrial product. These are my 2 little cents.
We developed the International Liver Cancer Association years ago, and now you are the president, exactly for this purpose, to put together different specialties, different fields of knowledge, beyond the interest of the industry. The industry is very good for something, and it may distort the evaluation of other things. And I think that scientific associations should put together the effort to expose the needs beyond the economics. So you have different partners in healthcare, and you have the governments, health agencies, you have the industry, but scientific associations of physicians or allied professions should be the ones leading the knowledge and the intellectual concepts. And I think this is the effort that has to be done, and we have to put together the East and the West, as I said before the meeting itself. Easy not, it's complex, but the first thing is to be willing to do it.
Definitely. Thanks so much for your contributions. Elena, should we move on to the next question?
Yes, I actually have another interesting question from the audience regarding palliative care. As the speakers just mentioned, the stakeholders like industry, physicians, I think palliative care is also a key part in liver cancer control. So how palliative care the palliative care aspects of liver cancer are being taken into consideration? Have the Commission talked about this point, and how do you see the regional differences in terms of palliative care? Who would like to answer the question?
Stephen.
Yeah, okay. Thank you. Quick notes. I'm sure Professor Zhou or Professor Dunn also will have a lot to share. Just quick note is in the paper, we did mention it. I think there's two important concepts. One is don't always think the palliative care is like terminal care. Even the patient with earlier stage or intermediate stage HCC, they still need some form of palliative care, either psychologically or physically. So then this moves to the second point, which we also emphasize is the palliative care is not wait till the patient till really late stage, symptomatic or terminal before referral to the palliative care team. The concept of palliative care should be introduced from the beginning and then being gradually introduced to the patient so that they accept more. And also there's some studies showing that their survival or quality of life can be improved. The last point is who is going to offer the palliative care. We didn't discuss in details in the paper, but I personally believe our even surgeons, oncologists, of course, palliative care expert, the physician, hepatologist, they also equip the principal training with palliative care.
Palliative care should be introduced from the beginning because patients face psychological issues when they are diagnosed with a disease. When they look into the internet or whatever, they are already told that they will die in less than 3 months. And this makes a shock in the patients and in the families and so on. But then they should be connected from the beginning so that when problems appear during the follow-up into late stage, they are already in the system and the patients have the feeling of being under a controlled setting. And this is what we do in our place and has provided patients with more calm and less stress than what happened before. But it requires the health system. Again, as I said, the health systems are very different in different parts of the world. And in Catalonia, we have a healthcare that works quite well, and we provide care from the beginning to the end. And in other places, this needs to be put in place.
With you, we should integrate the palliative care even at the early stage. Recently we published a study in Cell. Found the regarding the neuro-oncology, we found the nerve pain, nerve pain are related to the immunity of the patient, can influence the neural pain, can influence the T cell and macrophage. So in my practice, I always encourage my patients, even in the late, not only in the early stage, but also in the later stage, to encourage the patient. Even in the later stage, you can see lots of patients in our institute. So survive more than even 20, 30 years. This will relieve their stress, can enhance their confidence to enhance their immunity to anti the liver cancer.
One important concept that I feel we have to stress is that liver cancer is a complex disease and needs to have the different specialties involved. And this is what is named now the multidisciplinary tumor board and so on. The concept is that liver cancer is not owned by a specialty, not oncology or hepatology or radiology, whatever. So you need to have this exposure of the patient conditions to the different specialties so that there is a discussion about what is the best or the optimal treatment for a specific individual. And this is something that should be stressed because otherwise they lose the potential for transplant or lose the potential for resection or even for techniques that are effective such as ablation for early stage. And the only way to go is to have centers that are experts in the disease with a well-defined protocol of care so that there is a path of care that is defined, blended with research. And this is what is going to make advancements in the field because conventional care will be optimally applied and we will have the developments in research that are needed to further expand the benefits for the patients. And I think that this is relevant so that nobody decides to take care of patients alone in an isolated place without the needed expertise and knowledge.
Okay, I think we are almost running out of time. So Vanya, shall we wrap up? I think for everyone, let us have one sentence to conclude on the webinar today. Over to you, Vanya, to start the conclude of the webinar.
Right. Well, I think this has been a very productive and interesting, thought-provoking discussion. We clearly heard this is very complex. It's an issue that we cannot do together alone. We need to be together in this. As our editor-in-chief of the Lancet said, the only reason why we were successful at coming together and publishing the Commission report, why it was successful, was because we took together remarkable collaboration and of experts, and we really need the collaboration across specialists from around the world, from around disciplines, if we are to succeed in addressing the burden of liver cancer. You see, I heard a lot of issues from inequities to the industry interests to issues with access to care. I think there's a lot of problems, but there are lots of opportunities too. And I think if we look at all these issues as opportunities rather than problems, there are many doors that we can open, and I do remain very positive about the outlook of our future. Thank you all for taking part, and I wanted also shortly to highlight this webinar has been hosted in partnership with the London Global Cancer Week, and there have been lots of sessions. I don't know if you had opportunity to attend. Please do check the program of the London Global Cancer Week, which covers a lot of very interesting topics within cancer, the global oncology. Thank you again, and please. Around on my screen, I think the next one is Jen Shaw, if you have a last thought.
As our Lancet Commission recognizes that actually the whole process will be a gradual process that requires the involvement of multiple stakeholders, including policymakers, healthcare providers, international professional organizations, researchers, and patient advocacy groups. With joint efforts, we believe a large number of liver cancer will be prevented, and both the survival and the quality of life for patients with liver cancer will be considerably improved. Thank you.
Thank you, Professor Chen. Just one sentence to finish.
Okay, one word: complex disease. This is why we have a lot of room to improve. And every one of us has a role.
Very simple. Very simple. We know the present. We need to work to improve the future.
Fantastic.
Prevention is the most cost-effective way to reverse the rise of liver cancer. Thank you.
Helen, over to you to close.
Okay, so my last word is action today. And thank you all to, thanks for the audience to stay with us for an hour, and thanks for all our speakers. And we are so thrilled to be with you to talk about this very important question. And I hope you to read the commission later and stay on to this very important topic. Thank you.
Thank you.
Bye.